welcome to Alasdair Henderson. You can see the title of the talk. Usual rules apply. Alasdair will give his talk, and then I'll try and field the questions when we come to the end. So if you could take it away, Alasdair, that would be great.
Thank you, David, and thank you for the invitation. First thing to say is I'm presenting this jointly today with Ruth, who's here on my right. So we're going to talk about two related bits of research that we've done, all about what happened to non-COVID outcomes during the pandemic that we've just lived through over the last couple of years. So yeah, I'm going to talk for the first half, and then Ruth is going to talk about some more updated work in the second half. The title of the presentation is there. It's the title of a piece that was published in the Lancet Digital Health, and the QR code in the bottom right will take you through to the full paper that I'm going to talk through. But the first thing I wanted to say off the bat was that this was a massive team science effort. So I'm presenting today, but it was a huge project led by all the people you can see listed on the screen were involved in developing code lists and analyzing results and writing the manuscript, led by Kate Mansfield and Sinead Langan. So just wanted to acknowledge the wealth of support that went into making this work. So, as I said, it's going to be split into two, this talk. I'm hopefully going to talk first half, about 20 minutes, and then I'm going to hand over to Ruth to talk through some more updated work. So I'm going to be talking about research that we did in 2020, in the summer of 2020, which looked at GP records, and we just demonstrated the extent of the reduction of primary care contacts for a whole range of acute non-COVID conditions in England during the first lockdown. So that's the published research. Then we're going to stop the recording and hand over to Ruth, who's going to talk about some work in progress using Open Safely, and including results up to 2022, which is an analysis of how the pandemic affected clinical monitoring and hospitalizations for non-COVID conditions, and especially how this effect differed across different ethnicities. So that's the structure of how this is going to look like, and we'll leave plenty of time for questions at the end. This is a far too simplistic representation of primary care in the UK, in case people aren't familiar. Just to kind of put context on what we're talking about when we're talking about this data. So general practices, they're free of charge, and they are the first point of contact for any non-emergency health outcome in the UK. From primary care, you can get referred to secondary care for a specialist, or maybe you might end up in a hospital admission. But primary care is the first port of call, and according to NHS Digital, about 62 million people are registered at a primary care practice, a GP, in England, so which is basically everyone, and that's about 8,500 people in each practice. So if someone feels unwell, they have heart problems, they might go and see their GP first, and then it's up to the GP whether they want to refer them on to secondary care. My work in particular is just looking at primary care in general practice, so I just wanted to put that in context. And then the other bit of context is to kind of go back in time and think about where we were when this research was going on. So at the start of the pandemic, obviously this massive sea change was happening, big scary virus, and a huge amount of research was going to go into the effects of COVID, how to stop it, how to treat it, how to vaccinate against it. We went in a slightly different direction and really started to ask about what the pandemic would mean in terms of non-COVID health problems. And we really thought that it might lead to more non-COVID health problems for a variety of reasons, but it can broadly be bundled up into kind of three categories. One reason might be resource reallocation. So if doctors and nurses end up moving across to treat COVID patients, there might not be as much treatment access or monitoring and prevention of non-COVID outcomes, which could lead to worse health outcomes. Similarly, it might be harder for patients to access treatment because of lockdowns. That makes it harder to monitor and prevent these conditions. But also lockdown could have caused adverse health effects in terms of social isolation, closure of social spaces, a lot of unemployment or furloughing in the UK. Could also have a negative health effect. And then the broader point of it's very stressful to live through a pandemic, as we all know. So fears about anxiety increasing during the pandemic were real. So we thought maybe a combination of these factors might lead to an increase in non-COVID health outcomes across the pandemic. And we wanted to look at this to kind of supplement all the literature on how the pandemic was affecting COVID outcomes. But this research was done in the summer of 2020. So that meant two things really. Firstly, we didn't know about longer term health outcomes. So we didn't know about things that might have a long lag time between diagnosis and reporting in healthcare records. And we only had primary care data. So there was no linked hospital or death data at the time. So the two kind of major caveats to the research that was done in the summer of 2020. But still, we wanted to address this kind of main aim. What happened to general practice contacts for acute physical and mental health outcomes during the pandemic or during the first lockdown of the pandemic? Sorry, I just need to move this little Zoom bar. There we go. So this is an overview of the methods. I'll go through this in a bit more detail in the next few slides, but population we were looking at was basically anyone in England at risk of a series of non-COVID acute outcomes, and they were disease specific. So if we looked at anxiety, we looked at all individuals in England over the age of 11. If it was cardiovascular, we looked at individuals over the age of, I think, 41. And if we looked at diabetic emergencies, it was people with diabetes, etc. So the population changed depending on the outcome, but essentially anyone who's at risk of reporting with that particular disease. The exposure we were interested in was the March 2020 UK lockdown, so a stay-at-home order that came in March 24th. And the comparison was with pre-COVID contact rates at primary care. As I said, the outcomes were a series, I think there were 16 of them in total, of non-COVID acute diseases that I will talk through in a second. And this was generally a cohort study. So we followed people from 2017 through to July of 2020 and looked at changes in contact rates, both pre and post-pandemic. So the data we used for this was gratefully received from CPRD. We used the Aurum database. So as I say, this was data between 2017 and July 2020. And CPRD Aurum is an excellent database of primary care practices. It covers about 13% of the English population and included Northern Irish practices from 2019. And in total, that's about 19 million people. The data profile link is at the bottom there and states that this data set is broadly representative of the English population in terms of age, in terms of sex, deprivation, and geography, as you can see on the little map there on the right. In terms of what's recorded, a lot. Demographics, there's diagnoses and symptoms, which are probably most relevant to this study, but there's also prescriptions, referrals, data on immunizations, some lifestyle factors, and then tests and results. Anything that gets documented in your primary care, in your GP practice, should end up in CPRD Aurum, and we can investigate it to investigate trends in consultation patterns over the first lockdown. So the 16 outcomes we looked at, we wanted to look at acute non-COVID outcomes. We wanted things that were kind of unavoidable, you wouldn't delay treatment for. We wanted them to be kind of urgent, but they were all non-COVID conditions, so perhaps weren't the focus of most research at the time. So for example, we looked for diabetic emergencies in people with diabetes. The main area on mental health outcomes covered 6 separate conditions, from the far more common in terms of anxiety and depression to other serious but slightly rarer conditions like serious mental illness, self-harm, eating disorders, and OCD. We also wanted to look at respiratory exacerbations in people with chronic respiratory conditions, so people with asthma and COPD, and seeing how many times they reported with exacerbations of those conditions over the first lockdown. Then there was a basket of 6 different cardiovascular conditions, as you can see there, to try and get an idea of what happened to cardiovascular health over the first lockdown. And then the 16th, the final one, was acute alcohol-related events, seeing whether people were abusing alcohol. Sorry, I'm just getting tripped on by the aircon in here. Acute alcohol-related events as well. So how do we analyze these? The first was fairly simple because we didn't think there was any of this data out there at the time, essentially. So the first port of call was just to describe the data, and we made plots of the weekly proportion of the population at risk who would contact their GP for each of those conditions, and we compared that to the historical average. And then we could stratify these by a range of different demographic factors: age, sex, region of England, and ethnicity, to try and see if there was any kind of obvious patterns of inequity there. But once we described it, we wanted to put a number on it as well. So we did a formal analysis through an interrupted time series. So this is a form of analysis where you separate a time series into 2 periods around a clearly defined interruption, which we had here. We had a kind of lockdown announced on a single day. And then we created a binomial generalized linear model for each of the 16 conditions at time t, include a variable of zeros and ones to mark when got pre-interruption and post-interruption, and then you can estimate the effect of that interruption. But there is quite a technical challenge in doing that, in that you have to choose how that interruption will impact on your data. So here's 3 options that you can take. On the left is a very simple change in level. So the trend before and after the interruption doesn't change, but the level has. In panel B, you've got the opposite. So there's no immediate change, but there is a change in the rate after the interruption. We went for this option C. So we included a change in the level, and then we also assumed that the rate after the interruption would be different to before the announcement of lockdown. So therefore we get an estimate of the immediate change and also what was going on during the period we were living with lockdown. And this is what the model that I'll talk about later looked like. So YT, our outcome, was the proportion of that eligible population with primary care contacts for whatever the condition of interest was in week T. And then the other variables that went in was firstly time, it's just a linear count of the week of the study. And then this RT was our binary interruption variable. So it was 0 until lockdown, and then it was 1 afterwards. And then by using an interaction term between these two, that allowed us to assess the change in slope, so the change in the level after the interruption. And then we included 2 more variables to kind of account for seasonal trends in the data. The first was just calendar month. And then we included lag residuals from the model to adjust partially for the autocorrelation, so that each t was not as dependent on t-1. So that's what the model looked like. But as I said, the first thing to do was basically just look at the data. So as I said at the top, we were kind of expecting some of these conditions to go up over the lockdown. As you'll see, that wasn't the case. So to build these plots, we had data back to 2017. So we calculated the weekly percentage of people consulting for a condition. So here it's anyone over the age of 11 and whether they have a record in their GP records for any anxiety symptom or diagnosis. So on a given week in April 2017, about 0.2% of people who could consult with anxiety did. And you can see the trend over the year in 2017, and then we've got that data for 2018 and 2019, and then we can just take the average of all 3 of those years to kind of give us a pre-pandemic trend. Then the big thing we're interested in is how 2020 looked on top of that. So we can overlay the data for 2020 up until July of that year. And you can see the difference basically between the 2020 data and the historical average. And that big reduction, the red dotted line there is showing you March 24th of 2020. You can see the kind of reduction coincides with that announcement of lockdown fairly dramatically. The work, as I said, got published in the Lancet Digital Health. So the color scheme changed a wee bit, and I'll talk you through all 16 of them. The first 2 I'll probably talk briefest about because they were very small numbers and they're very dependent on kind of 1 or 2 codes. So they had quite a lot of volatility and slightly strange patterns. So diabetic emergencies really fell quite early in 2020. And acute alcohol related events had this kind of odd spike before the lockdown, then a reduction, then a spike again. So it was kind of hard to infer much from these 2 outcomes. So I'll probably brush over them mostly in the talk, but we can discuss afterwards. The pattern across the mental health outcomes was a bit more interesting. So you've seen the anxiety plot I just showed. You've got that reduction in around March 2020, and then you get a much larger one in terms of depression and eating disorders as well on the bottom left there. Are all much below their kind of historic averages. The back data for obsessive compulsive disorder, self-harm, and severe mental illness is all a bit messier, so it's a bit harder to infer anything from descriptive plots, but you can generally see a broad pattern here of a reduction in primary care contacts for mental health outcomes. Next is the basket of 6 cardiovascular outcomes. Along the top line, again, you've got the same pattern of a big reduction and lower levels in 2020 than we'd expect given the back data, especially in terms of heart failure and transient ischemic heart attack, I'd say. Unstable angina and venous thromboembolism, less of a clear pattern, especially for angina, which had very, very small numbers. And last but not least, the respiratory exacerbations. So asthma had this slightly odd pattern of a huge spike in contacts around the lockdown. We kind of hypothesized in the paper that it might be because of people getting prescriptions in the face of an imminent lockdown. But as soon as that spike is over, it reduces well below the pre-2020 level. And the same is true for COPD exacerbations as well. So the overall picture kind of answers the question, broadly speaking, what happened to general practice contacts for these conditions? They all essentially reduced. But who did that happen in and by how much was the next question to answer. The who I'll touch on briefly because the broad answer is everyone. So these are slightly different plots. The box plot shows just the weekly average prior to 2020, and then the lines show the data in 2020. And hopefully what you can see is just kind of this kind of wave of reduction over the lockdown. And you can explore these data for yourself at this shiny app link. So all the conditions, all the stratifiers are all there to play with. Broadly, what you see is everyone reducing over 2020. Although the work Ruth will present later will show kind of how you can look at this in a bit more of a systematic manner. But essentially, the lockdown affected everyone, and it probably affected everyone's GP contact patterns the same as well, or similarly at least. But the how much was the interesting bit, so that was trying to put a number on it. So to do that, this is the same data for anxiety as shown previously, just stretched out from 2017 onwards. We have our interruption in March 2020, and then we fit that binomial model I talked about earlier, which fits the data broadly rather well. And by doing the model, as I said, we get 2 estimates, one for the change in the level and one for the change in the slope. So for the anxiety example, the odds ratio for the change in level just shows you that immediate decrease around March of 2020. So that broadly means that on April the 1st, the odds of contacting a GP for anxiety was 0.67 times what it was on the 1st of March, essentially. I should say here, we removed the data in March because people's behavior was changing broadly over that whole month. So we thought it was safer to just kind of remove all that data as people adjusted to the restrictions at different times. But then we did some sensitivity analyses on that as well. So yeah, 0.67 is the reduction immediately around the lockdown. And then this odds ratio for the recovery, if it's over 1, it means basically the slope is positive and it's going to be increasing. So you can see the rate was increasing week on week, but it's still quite low. And by July 2020, the level is still clearly below that, what it was in March of that year. We fit these models for all 16 outcomes. As I said, they didn't work particularly well for diabetic emergencies or acute alcohol-related events, but for the rest, they produce a good fit and they give us those odds ratio estimates for all the conditions. So the blue line shows you all 6 mental illness outcomes we looked at, and the odds of recording a mental illness decreased. Odds ratios ranging from about 0.58 to 0.8. It's quite a dramatic and instantaneous reduction in the odds of contacting your GP for a mental illness. Same is true for most of the cardiovascular outcomes, with the exception of venous thromboembolism. And then there's this big discrepancy here between the asthma exacerbations, which reduced a little, and then COPD exacerbations, which reduced a lot. Broadly speaking, you can kind of see the quantification of the pattern that we saw in the descriptive analysis previously. And then in terms of the recovery, broadly, these were all positive. So the rate was increasing week on week after the lockdown, but they're all fairly low numbers here. So they're all positive for the mental illness outcomes and for, again, all the cardiovascular outcomes with the exception of venous thromboembolism. But the thing to note here is that these increases, they're not rapid, and that most conditions in July 2020 were not near where they were as lockdown was announced. Excuse me. So what does all this work highlight? Well, it's likely missed opportunities for care and a large burden of unmet need. And it would have consequences, intermediate and longer term consequences for both the NHS and recovery. But what those consequences are really depend on what the drivers of this reduction were. And it's unclear from these data what happened. So it could be that people avoided the GP for fear of infection or unwillingness to burden the healthcare system during that first lockdown and stayed away. Or it might be actual difficulty accessing services. We know all primary care basically switched to telephone and video conferencing very swiftly. So under those, if those are the drivers, then these are people who are still having these conditions but aren't reporting them, which is a worry, and that would be an unmet need. It might be, because we're just looking at primary care here, it might be that people never appeared at primary care and they presented directly to emergency departments or to specialist services instead. So linkage to other data sets is going to be really important in working out what the consequences of all this are. Or it could be that genuinely there was a reduction in incidence of these conditions over the first lockdown, which we can debate, but I think for certain conditions, so this is a paper looking at anxiety and depression using a kind of global burden of disease framework across many countries, and it basically generally shows that during the COVID pandemic, these conditions got worse. So yes, there may have been a reduction in incidence for some conditions, but for some of the ones we looked at, we'd really expect them to be going up, not down. So we need to kind of work out what happened to these people and where they went. But we were missing quite a bit in this first work because it was rapid and it was hopefully useful. But we didn't do much in the breakdown by characteristics. We didn't do anything in terms of international comparisons. And obviously we had quite a short follow-up. And as I've said before, we needed to link to hospital data. Some of those gaps are being filled. So these were colleagues at UCL, Claire Zhang and Yamini Bukhari led this work. They looked at migrant status and how that affected GP patterns with a similar method. They basically found that migrants use primary care less, but that the pandemic made these gaps widen, essentially, in this paper. In terms of international comparisons, it's clearly going to be very context dependent. So here on the left, you can see in New Zealand that eating disorder admissions went up in 2020. And in Norway here, this is primary care. I'm looking at psychiatric referrals, essentially, and any kind of anxiety and depression code. Again, they did not see the same reduction over lockdown compared to the historic average. And afterwards, they had higher levels in 2020. So this could be a unique experience with the UK, but this international kind of context is going to be really important in this research, I think. And in terms of the longer follow-up, this is my last note, just to pay credit to Olivia Bryant, who's an MSc student and is doing this work as part of her MSc dissertation. But just basically repeated the work for the mental health outcomes over a longer time period up until May of 2021. So this is the full data for 2020 on the descriptive side of things. You can see some conditions like eating disorders were catching up to their historic averages by the end of 2020, but some like depression was still well below and severe mental illness. And then this is the information for 2021. The gaps have really closed on a lot of these conditions, which is good news, but for depression and severe mental illness, they're still well below what we'd expect if the pandemic had never happened. There's clearly a lot more work that needs to be done here and a lot of catching up to do in this kind of unmet need. And there is still so much more to explore. So with that, I'm going to stop talking and pass over to Ruth